Good afternoon. After all that difficult cases and those real challenging cases, let's go back to a bit of basics again. Okay, right at the outset, I would like to thank Wavikar Eye Institute and Dr. Wavikar for this opportunity. Okay, the dry eye per se affects every aspect of life, whether it's the physical health, the sleep health, the psychological health, and studies have found that it is as much as the prevalence of dry eye is about 50% of the general population. It also affects various activities like reading, driving, computer usage, and professional work. And again, there are studies to find that the difficulty levels are increased to almost about 2.5 times in cases of patients with dry eye who are using artificial tears, and this goes up to almost 5 times in cases of patients who are not using artificial tears. And this impact of dry eyes is in fact comparable to quite a few other disabling conditions, as serious as maybe a disabling hip fracture or maybe a severe angina. Now, dry eye is common but difficult to diagnose, and even in the Indian scene, Titial and all have found that the prevalence of dry eye is up to 32%, out of which almost 60% fall in the moderate group and about 30% in the severe group. And thus, 81% of the patients have dry eye symptoms, and the main problem is the diagnosis. So what are the challenges in dry eye diagnosis? Basically, the definition of dry eye today is still debatable. There are no gold standards for the diagnosis of dry eye. Most diagnostic tests are poorly standardized. The ocular surface is sensitive to stimuli and diagnostic tests are invasive. Non-invasive tests are available in quite a few centers today, but there are centers where they find it too expensive and we do not have non-invasive tests. And in cases of reduced ocular surface sensitivity, the tests are poorly associated with the subjective symptoms. Let's now understand what happens with the unhealthy ocular surface. So an unhealthy ocular surface would give rise to a tear film instability, and this would also result in blurred images, whether it is following a cataract surgery or following a refractive surgery. The types of the dry eyes, depending on the type of tear deficiency, would be classified into an aqueous deficiency dry eye or an evaporative dry eye or a mixed type. And this can be due to intrinsic as well as extrinsic factors. So as we all know, that the tear film is made of almost the aqueous layer and the mucin layer and the lipid layer. Almost 50% of the dry eye cases are due to a lipid layer deficiency, and there are almost about 30 to 40% cases which fall in the cases of combined lipid as well as aqueous deficiency. So almost 86% of the dry eye cases are somehow or the other related to lipid layer deficiency. The problem what we had until now was the absence of a good lipid-based artificial tears, which would also be patient-friendly, as in it would not cause visual blurring. We had liquid paraffin-based ointments which were used, but again these couldn't be used through the day because of the blurring which was associated with it. So the lipid layer, like we know, has the outer non-polar layer or the air interface, the inner polar layer which is the aqueous interface. So basic cause of lipid layer deficiency is a meibomian gland dysfunction and blepharitis, which could be a rosacea blepharitis, a seborrheic dermatitis, or due to the desmodex infection. So how does one diagnose the lipid layer deficiency? The most common is doing an ocular surface analysis with an IDRA, which will give you the NIBUD, that is a non-invasive breakup time, a meibography to know the conditions of the meibomian glands. The lipid interferometry will give you the exact condition or the exact position of the lipid layer and the tear meniscus height. So the management of the dry eye would include certain important goals, and that would be to relieve the symptoms of dry eye, to prevent corneal damage, to improve the patient's ocular comfort, and to return the ocular surface and the tear film to as far as possible as a normal size. These two recommendations stress on certain things. That is, in the first phase, you have a proper education of the patient regarding his disease condition and the management. Preventive measures which would include a change in the environment, preventing the AC draft coming directly on the eye, dietary modifications as and when required, ocular lubricants, and lid hygiene. The step 2 would be using of non-preserved ocular lubricants, treaty oil in cases of desmodex infections, anti-inflammatory agents, and tear conservation approaches, which would include punctal occlusion, and maybe in severe cases, moisture chamber spectacles. The third step would be in the form of oral secretagogues, analogous serum tears, and therapeutic contact lenses when required. And for the most severe cases, would require a long-term treatment with topical corticosteroids, amniotic membrane graft, surgical punctal occlusion, or other surgical approaches. So basically, what one needs to understand is that in cases of tear film deficiency or in cases of mixed dry eye, one needs to treat the tear film, the lipid layer. And in order to treat the lipid layer, we start off with the meibomian gland dysfunction, so warm compresses. In cases that doesn't work, one would have to supplement it with an IPL therapy or an IRPL therapy, a low dose ophthalmic ointment, and certain types of artificial tears. So basically what happens with artificial tears is, it's considered the first line treatment in dry eye disease, and these are basically typically buffered solutions that contain electrolytes, surfactants, and one or more viscosity modifying agents, which may or may not contain preservative, though today we would always go in form of a preservative-free artificial tears. They increase the tear film stability, improve visual acuity and contrast sensitivity, and it is important to determine whether the major cause of the dry eye is predominantly due to the aqueous layer deficiency or due to the lipid layer deficiency, like I said. Alcon today has now introduced Cysteine Complete, which basically works on the lipid layer and the mucoaqueous layer of the tear film. It increases the lipid layer thickness and has a high level of satisfaction. So what it contains basically is mineral oil and phospholipids and HP guar. HP guar we've been using in the form of Cysteine Ultra for quite some time today, and polypropylene glycol and boric acid. Now the lipid in the Cysteine Complete is basically given in the form of nanoside lipid droplets, which replenish the lipid layer of the tear film. HP guar increases the mucus layer thickness and protects the ocular surface. Now how does this lipid is different from the lipid which was there in the paraffin wax ointments? Basically this does not give rise to the blurring because these are nano emulsion. And the particle size of these lipid droplets is less than 100 microns, just 100 nanomicrons, and this decreases the blur. At the same time, these nanoside lipid droplets allows for the enhancement and of the concentration of the HP guar as compared to the larger size lipid droplets. So HP guar, like we all know, is very biocompatible, and once inside the eye, it cross-links with the borate, aiding in the retention of the demulcents and enhancing tear film stability. So basically what happens with Cysteine Complete is it spreads around the whole ocular surface. The HP guar forms a hydrophilic meshwork cross-linking with the mucoaqueous layer and creating a protective elastic matrix. The nano-sized lipid droplets migrate to the surface and therefore it helps to replenish the top liquid layer by filling in any gaps which are there in the lipid layer. And therefore it acts as a complete protection to the tear film. There have been two clinical trials which are of importance. One is by Silverstein et al. And the other one is by Craig et al. And both these trials have shown that almost 63% of the patients reported significant relief after a single dose of Cysteine Complete at 8 hours interval. There's been a sustained improvement in the tear film stability from 3 months onwards in both the treatment groups, and improvement in the tear film lipid layer from the 3rd month onwards, which was very, very significant in the Cysteine Complete group as compared to the Cysteine Ultra group. Now, I'd like to show a few clinical cases which we have encountered and which we have been using, for which we have been using this drug. So this was a case of a 26-year-old female who came for a LASIK surgery. Her Schirmer scores were low. Actually, this patient was brought in for a LASIK surgery by a referring doctor. And in spite of low Schirmer scores of 16 and 15, she wanted to undergo LASIK on the same time. A femto LASIK was performed, and she regained a visual acuity of 6/6. She was continued to the normal regime with topical steroids, antibiotics, and artificial tear substitutes, which went on for 3 months. But what happened was, after stopping of the artificial tear substitutes at the end of 3 months, she complained of severe blurring, burning sensation in the eye, and unclear vision, loss of contrast sensitivity. We did an IDRA for this patient, and what we found here was that the lipid layer thickness was as low as 41 and 42 as compared to a normal. So here, because of this, what we decided was to start this patient on a Sustained Complete. Patient was given 3 months Sustained Complete, and 3 months later we repeated the lipid layer, and there you saw that the lipid layer had really improved. Now this is something which was never seen before. The lipid layer improvement was never occurring before in the ages of Cysteine Hydration or Cysteine Ultra, which we used to use in the past, or any of the other lubricants. Again, this was another case where an elderly patient was complaining of blurring of vision in both the eyes. She had a grade 2 nuclear sclerosis with PSC cataract with very low Schirmer scores of 9 and 12 millimeters. Her IDRA here again showed a very low lipid layer. And so what we planned for this patient was to start her on Sustained Complete, but since we couldn't wait for 3 months for a cataract surgery, we decided to give her 2 sittings pre-operatively of an IPL. Now this was done at day 1 and day 15. The patient then underwent cataract surgery with a premium IOL implantation and was continued for the next 3 months on Sustained Complete, and the third sitting of the IRPL was completed at the end of 1 month after the surgery. Now again, after 3 months, an IDRA was repeated, and there we find a much better condition of the lipid layer, which was not possible with probably non-lipid containing lubricants. Again, this was another case where we had an elderly lady with dryness in both the eyes since 5 years, Schirmer scores very low, again a very low lipid layer, and having treated for her dry eye symptoms with the Sustained Complete, we found that her lipid layer thickness after 4 months had really improved. So in summary, the dry eye is a common condition which affects practically all aspects of a patient's life. It can be a condition which can reflect poorly on excellently done refractive or a cataract surgery. It's difficult to diagnose, but it's important to find the difference between the aqueous layer deficiency and the lipid layer deficiency. And using a tear substitute which hydrates the eye at the same time which improves the lipid layer can definitely go a long way in the treatment of this lipid layer deficiency. Thank you.
Thank you, Dr. Nitin. Wonderful talk. I request Dr. Wavikar sir to felicitate with a bouquet.
Good afternoon, everyone. It has been a fabulous series of talks, and because of that, we have just run out of time. I would like to thank all the moderators. I would like Sir to give the memento to Dr. Mridula Bhave. Dr. Rajesh Kapoor. I would like to call the Alcon team, without which it would have been not possible. Thank you for your exceptional support. I would like Sir to give the bouquet to them. I would like to thank our home team from Wavikar Institute. Please come up on stage. Dr. Kale sir, Dr. Prachi, Dr. Richika, Ms. Namrita, Ms. Pravida, Amol. Thank you everyone, and thank you to all the audience for joining us today. Please have your lunch. Thank you.